Our TRH stimulation test is used less often today, but does remain helpful when distinguishing secondary versus tertiary hypothyroidism. In primary hypothyroidism, the pituitary is functioning, so TSH rises significantly after TRH stimulation. But in secondary hypothyroidism, there's no TSH response because the pituitary is defective. In tertiary hypothyroidism, the response is delayed. The pituitary is intact but has been understimulated by low TRH. This test helps to localize where the dysfunction occurs along the axis. Looking at our actual active hormones, T4 thyroxine makes up more than 90% of circulating thyroid hormone and is almost completely protein bound. Only 0.2%, actually 0.02%, is free and biologically active. The total T4 test measures both bound and unbound fractions and is useful for diagnosing hypothyroidism or hyperthyroidism. Remember that because it's so protein dependent, total T4 alone can be misleading when binding proteins are altered, such as in pregnancy or chronic illness. In fact, I almost exclusively measure free T4 at this point clinically. We all screen newborns though for free T or for T4 levels to detect congenital hypothyroidism early because without early treatment, infants can develop profound cognitive impairment because thyroid hormone is so essential for brain development. Conditions like cretinism arise from untreated neonatal hypothyroidism. And factors like iodinated contrast or pregnancy can artificially elevate T4 levels, so we do need to always keep in mind, of course, clinical context. Normal T4 ranges do vary slightly by age as well as gender. There's slightly higher values in our AFAB population compared to AMAB, and they decline slightly in older adults over the age of 60. Critical levels matter clinically. A T4 below 2 may indicate myxedema, coma, with levels above 20 raise concern for a thyroid storm. You always want to pair, though, T4 results with TSH to understand whether the abnormality is primary versus secondary. When you have a T4 that is decreased, you could consider primary hypothyroidism, a hypothalamic failure, or a pituitary failure, iodine deficiency, certain medications even. In contrast, a total T4 that increases could be considered hyperthyroidism or an acute thyroiditis, exogenous thyroid hormone use, and an increased TBG state. A particularly important pitfall is that an increased TBG leads to a falsely elevated total T4, while the free T4 remains normal, which is why we prefer free hormone measurements when we're assessing thyroid. There is a hereditary condition that can cause abnormal albumin binding to thyroid hormones stronger than normal, an increased affinity. And this leads to elevated total T4, but normal free T4. But a clinically euthyroid patient is another diagnostic pitfall because it can mimic hyperthyroidism biochemically, but not clinically. Recognizing this, again, familial dysalbuminemic hyperthyroxanemia. No one wants to say that 3 times fast, but recognizing this in patients can prevent unnecessary treatment in patients that have a normal thyroid function, but just abnormal protein binding. TBG does have a major impact on total T4 levels, as during pregnancy or when taking estrogen-containing medications, TBG will rise, which increases total T4 but not free, which is why pregnant patients may appear biochemically hyperthyroid on total T4 alone. But if you measure TBG or simply rely on free T4, it'll avoid any misinterpretation. Now, our T3 resin uptake or T3RU is another measurement that indirectly looks at the number of unsaturated binding sites on TBG and TBPA. It doesn't measure T3 levels, though. It's important to note it's not a measurement of T3, but it's if you have an elevation in T3RU, it suggests fewer available binding sites, which typically is due to elevated T4 or low TBG. Low T3RU usually indicates a high TBG or true hypothyroidism. This test was designed to interpret total T4 more accurately, but we primarily still are just using direct free T4 testing at this time. So I clinically don't really use this test. But a T3 resin uptake test, if you were to measure it, has to be interpreted alongside a T4. If T4 and T3RU change in opposite directions, the issue is usually a binding protein abnormality. If they change in the same direction, this usually reflects true hyper or hypothyroidism. Interfering factors like recent radioisotope exposure, certain meds can alter your results. But again, modern testing has made this test pretty much obsolete, but it's important historically and it's important to understand thyroid physiology. If you did have see this measured, or if you see a patient that has this result, a T3 resin uptake reflects again how many thyroid binding sites on TBG and TPA are unsaturated. We can see normal findings being between 25 to 35%, versus we can see some interfering factors here. And this would be some causes of increased versus decreased levels. Lastly, a free thyroid index adjusts total T4 for variations in binding proteins. It's a calculation. I'm not going to make you do it in this class, but it's calculated by using total T4 multiplied by T3RU divided by 100. So it creates a percent. It will compensate for changes in TBG and TBPA, so it provides a better estimate of actual thyroid status than a total T4 in situations like pregnancy or liver disease. But again, a free T4 assay replaces this FTI. So again, if you see it, I wanted you to have clinical context of what it could mean. But if you did a free T4 measurement, it just kind of replaces the need for that information. We will come back and we'll talk about some diagnostics now for hyperthyroidism and then looking at some autoantibodies before we close out.